which was below target. The next one was coverage of weight and height taking. This is for child survival development monitoring under strengthening of public health. The target was 55%. The performance under review was at 66%. This indicator was fully met. The next one is proportion of children attending developmental milestones at an appropriate age. It's still an important child survival development indicator, Honorable Chairperson. The target was 40%. Our performance was at 99.9%. So this particular development indicator was fully met. The next one is percentage of fully immunized children at 2 years. The target was 70%. The performance under review was at 69.1%, slightly below the target. The indicator was partially met. The next one, still under strengthening public health, was percentage of babies initiated to breastfeeding within 1 hour of birth. The target under review was 86.5%. Our performance was just above that target at 86.6%. It was fully met. The next one is the proportion of children under 5 provided with insecticide-treated net. It's an important child survival development indicator. The target was 100%. Our performance was 79, roughly 80%. It was partially met. The next indicator is proportion of under 5 children cured for severe acute malnutrition, which was looking at the cure rate for malnutrition. The target was 80%. Our performance was 75.9%, which was partially met. Honorable Chairperson, I'll move on to the next set of indicators measuring the performance of this strategic area under strengthened public health. The first indicator is family planning, which is proportion of family planning new acceptor aged 15 to 49 years, which is the reproductive age group. The target was 20%, 20.1%. Our performance was 18.6%. This indicator was partially met. The next one was proportion of districts meeting minimum standards to prevent and respond to health risks. This particular cluster also covers epidemic preparedness and control. So this particular indicator of proportion of districts which are meeting minimum standards to prevent and respond to health risks, the target was 100% in terms of preparedness. Performance was 100%, and this particular indicator was fully met. The next indicator, Honorable Chair and Honorable Committee members, is number of advanced field epidemiology training programs, field epidemiology training programs per 200,000 population. This particular program is aimed at strengthening capacity of the districts in epidemic preparedness and control. The target was 57 over 200,000. Our achievement was 35 over 200,000, slightly below half the target. The next performance indicator was the number of health threats investigated as a proportion of all threats reported through the surveillance system. It is another very important epidemic preparedness and control indicator. The target was 100%. The achievement was 100%. On health security and surveillance, there was an indicator to measure the proportion of districts submitting at least 80% of weekly ND2 notifiable disease 2. This is a requirement by law. notification form under the Integrated Disease Surveillance and Response System, facility reports. The target for reporting was 100% under the ND2, and the achievement during the year under review was at 79%. So this particular indicator was partially met. Then another very important indicator under strengthening public health is on mental health and substance abuse management. And the indicator was to measure the percentage of mental disorder caused by alcohol, which is a contribution of alcohol-induced mental disorders to all mental health-reported disorders. The target was 0.07%. The performance remained at 0.13%. The next set of indicators, Honorable Chairperson, are looking at strategy number 2, which is increased access to quality health care. The first of indicators are looking at infrastructure development as program output. Indicator number 1 was meant to measure the proportion of functional and essential equipment at each level of care. This is for first level hospital. In general, district level hospitals. The target was 33%, performance 33%. The status, this indicator was met. Still on infrastructure development, we were supposed to measure the proportion of functional and essential equipment at each level of care. This is now for second level hospitals. In other words, general hospitals. The target was 33%, the achievement was 33%. It was also fully met. The next infrastructure development indicator is looking at the functional or the proportion of functional essential equipment at third level, which is a tertiary level of hospital care. The target was 33%, the performance was 33%. It's also fully met. Honorable Chairperson and Honorable Committee members, the next set of indicators looking at increased access to quality health care specifically look at availability of recommended equipment in facilities. There is an indicator that measures the percentage of functional ambulances or runners, health centers at health center and health posts, percentage of functional ambulances, meaning that they should be runners. The target was 70%. Performance under review was at 70%. The next indicator is on percentage of functional ambulances, means runners, for hospitals. Levels 1, which is district, level 2, which is general, and level 3, which is tertiary. The target for transport availability was at 70%, and the performance was 70% as well. I will quickly move on to the next set of indicators, Honorable Chairperson. Under strategy number 2, which is still increased access to quality health care, and this particular cluster of indicators aim to highlight the availability of essential medical supplies, or in short, vaccines. Indicator number 1, percentage availability of drugs and essential medical supplies, in brackets BCG. The target was 100%, performance was 100%. Honorable Chairperson, may I mention that for all the vaccines, BCG, OPV3, DPT3, measles, the target was 100%, And the performance availability was also at 100% for the vaccines. May I also add that on medicines and medical supply chain availability or management, there was an indicator on ARVs availability. The target was 100%, and at the time of review, the performance was also at 100%. Honorable Chairperson and Honorable Committee members, the next set of indicators is still looking at increased access to quality health care, specifically on availability of essential medicines. The first indicator was to measure the percentage availability of drugs and essential medical supplies, in particular tuberculosis. The target was 100%, and the performance at the time of review in terms of availability of TB drugs was at 100%. Medicines and medical supply chain management. The percentage availability of drugs and essential medical supplies, in particular antimalarial drugs. At the time of review, the target, of course, was 100%. The performance was also at 100%. And Chairperson, I seek your indulgence that we are making a correction here. When we re-verified the statistics, we would like to report that the performance was actually at 70% and not 100%. The next indicator is on other essential medical supplies. In general, the target was 90% other tracer drugs, and the performance at the time of review was at 45%. The next set of indicators looking at access to quality health care is on human resources development. The indicator was to measure the percentage of facilities with at least 80% of professional staff on establishment field. The target was 80%. This particular indicator was achieved at 100%. The next set of indicators, Chairperson, is under Improved Health, Food and Nutrition Strategy 4, which is Improved Integrated Health Information System. On integrated health expenditure improved, we have an indicator on health sector budget as a proportion of the overall government budget. The target was 80%, and the proportion allocated in real sense was 8%. So that indicator was fully met. Under Strategy 4, Improved Integrated Health Information System. In terms of Health Management Information System report completeness rate, we had a 99% performance, which was, again, a fully met indicator. The next indicator was proportion of facilities with functional electronic healthcare systems, smart care, ELMIs, and DISA. At health post and health center level, the target was 50%. We achieved a 50%, which was meaning that the target was fully met. At hospitals level 1, 2, and 3, we had a target of 70%, the performance of 70%. This indicator was also fully met. The next indicator is provision of institutions, proportion of institutions using Navision at province, district, and hospitals level 1, 2, and 3. For the provinces, the target for using Navision was 100%. The achievement was 100%. For the districts, it was 93%. Our performance was 100% in terms of facilities using Navision. Hospitals level 1, 2, and 3, our target was 65%. Our performance was also at 65%. The next tranche of indicator was on percentage of research studies disseminated. The target was 25%. The performance was at 33%. Honorable Chairperson, the next tranche of indicators is on Strategy 5, which falls under reduced poverty, vulnerability, and inequalities, specifically to reduce vulnerability associated with HIV and AIDS. First set of indicators looks at percentage of people cancelled and tested for HIV. The target was 80%. Performance was as 8.7%. The next indicator was percentage of people cancelled and tested for HIV below 10 years. The target was 80% and the performance was at 85%. The next one is percentage of people on ART between 10 to 19. The target was 92%. Performance was 95%, and this indicator was fully met. The next one on HIV testing and treatment was percentage of people on ART above 20 years. The target was 92.5%. Performance was at 95.12 or 12%. This was also met. The next tranche of indicators under HIV testing and treatment were to do with percentage of people living with HIV who are virally suppressed. Category number 1 was those below 10 years. The target for the category of people below 10 years living with HIV and AIDS who were virally suppressed was at 89.5%. The performance was 84.4%. This indicator was partially met. The next tranche under HIV testing and treatment for people living with HIV/AIDS was the category of age group 10 to 19. The target was 86%. The performance was 87.6%. And the last category was people above 20 years living with HIV and AIDS who are virally suppressed. The target was 93%. Our performance was 94.9%, and this indicator was fully met. Honorable Chairperson and honorable members of the committee, I wish to submit in summary that the overall performance for the strategic areas covering strengthening public health, increase access to quality health care, strengthen integrated health information systems, and of course the reduced vulnerability associated with HIV and AIDS had a total targets of about 50. Out of those 50, 34 were fully met, 13 were partially met, and only 4 were below performance. I submit and wish to thank you.
PS, thank you for the submission. Honorable members, any questions? Honorable Dr. Kalila, I expect a question. Okay. So I say 3 hands. We'll start with Honorable Dr. Kalila, Honorable Samakai, and Honorable Musanja in that order. We can start.
Yeah, so thank you very much, Chairperson. Allow me, Chairperson, first to commend the team for the presentation, which I can describe as more realistic than what is presented in this report. I was actually coming to...
Are you able to speak closer to...
Yeah, I was actually coming to dispute and question this 22 annual progress report, except for the fact that my colleagues have made a number of revisions or corrections, and therefore I'll just restrict myself to 2 questions. First of all, this report, Chair, as you know, gives us the fact that under the outcome of nutrition and, of course, health and nutrition, that they reviewed 41 output targets and that 35 were met, and the report categorically puts the performance at 85%. The team here, which I agree with, have said that the performance, according to the submission you gave us yesterday, Chair, that it's at 65%, meaning that they have reviewed it downwards, and they have given some reasons, especially on medicines and medical supplies. They have given corrected figures, as the PS has indicated. You will recall, Chair, that in 2022 we also undertook a study on these medicines. In fact, at that time, as PS has indicated, the average was 45, although we said 53, the report was rejected, but it's another story, and I think that that's what I was going to question this report. Secondly, the PS has again given a different set of output targets, I think 50 from what I heard in his conclusion. Okay. In the presentation, the output targets are 43 and 28 met. I'm sure all members have that. So the question I have is, who informed the Ministry of Finance on some of the information which they presented in this progress report? And remember, Chair, we had almost left the Ministry of Health out. So if they had not come today, we would have gone with what is in this report. So I don't know if it was the same ministry which informed our colleagues at Finance, or they just put up a report on their own based on some other reports from somewhere else. I don't know. I just need some clarification so that going forward we need to believe these reports or documents that come from authoritative institutions such as the Ministry of Finance, particularly for the National Development Plan, because it draws its information from the sectors. So I just wanted to know about that. Secondly, whether the ministry had sight of an implementation plan for the 8th National Development Plan and did compare the implementation targets in there with regard to what they are reporting. I'll just ask 3, Chair, because I see that you don't like us going beyond 3.
In fact, beyond 1.
No.
Oh, you
I'm just about to ask the 3rd one.
Okay.
The 3rd one, I noticed that the results are mixed.
Okay, Doc.
Very good in some instances, so it's expected. But I'm very concerned on the underperformance, particularly in certain areas like child survival. Remember, we on immunization, under 5, malnutrition, insecticide treated. So basically, there's some underperformance in this area of child survival, and that's a critical area. PS, do you intend to look into this, and what could be the reasons for that? Thank you. I'll end here and leave my colleagues to take it up. Thank
you.
Chair, my concern is on the increase to the proportion of functional essential equipment, which is 1, 2, 3, and I can see that what was achieved was 33, which is 33%, which is equivalent to 1 to 3, and I think the targets PS, in my view, maybe you can justify. The targets, in my view, are too low, and we have a lot of problems in our hospitals regarding the issue of, functional, essential commodities, essential equipment. Are you thinking of, increasing the targets going forward? Because these targets are too low.
Okay. Honorable Musanje.
Thank you so much, Chair. And thank you, PS and team, for a very detailed and well-presented report. This is definitely better than what we got from the Health Committee last time. Yeah, I take the questions asked by both Dr. Karila and Honorable Samakai. I also had them, so I'll skip those and come to mine. Just to add on, maybe I'll go to a bit of specific ones. On tuberculosis, I note that we are only talking about notification. How about treatment outcomes to especially establish the cure rate, so that we know that these people are completing their treatment and they are cured. And then I saw that the cancer sites are only target 30% when we have a huge problem countrywide. I'm wondering what is stopping us from going to more sites, given that we have increased health coverage now. All the target for human resource was met. We have professional staff in all the health centers now. So why are we not going everywhere to do cancer screening? And then the last one is on research. I note that we are just measuring we said research target 25%, performance 33%. I would be happier if we reported on what is the specific contribution to the body of knowledge, discoveries, solving certain problems, to say this research contributed to this body of knowledge, or we solved this, or it helped us solve this. What is the outcome of that research, rather than just mentioning the number of research studies done. So overall, I think 65%. I think we need to really do a lot, considering that health is the number one requirement in all our lives. So definitely we need to do a lot. Thank you, Chair.
Okay, PS, you can respond to those, but just a caveat I think I've heard about 2 or 3 questions, which are almost implying that the targets are low. We need to. Now this is just a review. They are already in the implementation plan. You know what I mean? You want the targets to go up, but our colleagues are responding on what is not in the implementation, in the review. Those targets which are already embedded there. So maybe you can explain in terms of the concerns are that whilst we understand these are the ones which were given. Can you do more so that we at least we are able to achieve much higher than that? So PS, with your team, you can respond to those before we go to the next and final round of questions.
Thank you, Honorable Chairperson. With your indulgence, I will be asking my colleagues to chip in as well. And thank you for the good interventions from Honorable Christopher Karila on the issue of the number of targets from 43 to 50. I think because we've included the indicators on reducing vulnerability associated with HIV and AIDS, which are 7. So those 7 added to 43 gives us 50. But if we remain at 43, it is correct. I think as you have put it, that 28 were met out of 43, and 11 were partially met. Only 4 were below performance. So that is, correct, in line with the report. Yes, our annual plan, our annual activity plans And first and foremost, our sector strategic plan is actually anchored on the 8th National Development Plan. And our annual planning process, including the budgeting process, actually falls within the national budgeting framework. And the activities are anchored to the strategic areas or priorities highlighted in the 8th National Development Plan. So to answer that question, yes, we had sight of the implementation plan of the 8th NDP, and we continue to ensure that our activities, activity plans annually are anchored on the 8th National Development Plan priorities. On child survival indicators, I'll request the Director of Public Health to comment on what we are doing to beyond the targets in the 8th NDP to improve on child survival indicators. Director.
Thank you, PS. Honourable Members of Parliament, I think one of the reasons that we had a low performance has been explained in the report that we submitted, and this was mostly due to the fact that we had one of the key vaccines that are essential to our routine vaccine immunization was not available on our program the whole of last year. And so when we check for adherence to target in terms of fully immunized, this is one of the key vaccines that are needed for us to determine that a child has been fully immunized. But we didn't have it, and it was not the fault of the program, but the vaccine was just not available on the market at the time. And so that's why we recorded a poor performance in that regard. With regards to attendances at the health facilities, what we have noted is that when children between 0 and 5 years old, the parents usually bring their children to the facility when they are bringing their child for a vaccination. But the rest of the time, even when we say we want them to come to have their children weighed, just weighed without other interventions, I think this makes parents a little bit reluctant to bring their children, because there's nothing else they're coming for except for a weight measure. And so you find that during the first year of their lives, babies are brought every month from age 0 to about 6 months, because they're coming to receive a vaccine, and then they receive another vaccine at 8 months, another one at 12 months, and that usually counts for these 7 or 8 contacts that we see them. Beyond the vaccination, when they're supposed to be coming for weight measures and maybe to get some vitamins, parents rarely bring their children, and we only see them maybe when we follow them out in the field on outreach. So we are planning as a program to see if we can find other interventions, like for example increasing on our outreach activities, which we didn't do a lot last year due to constraints that have been determined or rather noted in the report. We want to increase visitations to the families, going to them rather than having them to come to our facilities, because some are too far anyway for them to come to just for a weight measure. I submit. Thank you.
Thank you, Honorable Chairperson. We also hope that with the increased access to health services generally, because sometimes it's an issue of physical access in terms of distances, we are hoping that as we increase the number of facilities, open more health posts and health centers, these under 5 children who have a much easier access to services, because sometimes what hinders utilization is the long distances. Allow me to invite Professor Mlenga to just comment on the issue of TB notification versus cure rate, which the program by and large is focusing on. Professor Mlenga.
What you can do is you can come near where there's a mic here.
Thank you, Permanent Secretary, and good morning, members of Parliament. We really appreciate the question regarding the notification rates and also the cure rates. So whereas we did report the notification rate of 91%, the cure rate is also quite impressive of 92%. But we do understand that even 92%, there are some challenges over which we did experience, especially as we are coming out of the pandemic, the post-COVID pandemic, which do relate to drug resistance patterns. We have had some of the people not coming back to the facilities because the community interventions were also reduced during the pandemic. That's why when you look at the cure rate, we have about 80% of people who did not respond adequately. And of course, this is a concern. I think in line with also what the Permanent Secretary did highlight, as we move the services closer to the community, especially in the spirit of decentralization, we believe that this would also help in increasing both the notification and also the cure rates so that we can avert the issues of drug-resistant TB spreading in the communities. Thank you so much.
Did they respond to your question about the research? There was an issue,
No,
not yet.
we
Okay.
are coming.
Okay.
You can go ahead.
Okay.
Honorable members of parliament, let me also just highlight the issues of research. Yes, I think it would have been desirable to report in terms of what information has gone out both to the public and also to the healthcare workers. We had the National Health Research Conference, and the National Health Research Conference is the main area where we do disseminate research findings. The research which did take place, of course, spans from both infections and also to non-communicable diseases. But we also had a number of dissemination happening at different fora, both the local conferences and also the international conferences. In terms of measuring how much of the information was received by the community, we do not have any indicator which would be able to provide that, but that is well noted on how we can measure how the impact is. But there are a few things which we can highlight, like we can highlight the research around TB. It has informed the public on how best to modify how we manage TB during pandemics. That was observational research which was done in Zambia, and WHO has picked up as a model. On the HIV sector as well, we completed a trial which has changed how we manage those that are failing the first line, and WHO has picked up those. Those are the two which I can highlight as the two successes which globally have been taken to scale because of the research done locally. Thank you.
Thank you. Yes, on the issue of the equipment, Honorable Chairperson, we do agree that the targets are lower than what we also have in the strategic plan for the sector. However, as a sector, we are striving to have nearly all the essential equipment functional in the facilities. So our targets are much higher, especially for the essential diagnostic as well as equipment used for treatment. So we'll continue to strive as a ministry to ensure that the equipment, essential equipment available at all levels of care is functional and available for improved care of patients. I submit.
Thank you. Honorable members, let's take the last two from Honorable Nyambose and Honorable Kafoya.
There was also a
Thank
question.
you. Oh, sorry. You know, Honorable members, you loaded me with a lot of questions, so some of them I haven't kept track. PS.
There was a question on increasing cancer screening, which we agree in terms of increasing the sites.
Oh, yeah.
Again, there are efforts that we have put in place. I think recently you may also have heard that we have started construction of a fully fledged cancer center on the Copper Belt. And we are hoping that as we decentralize this service, we will make the service, bring the service as close to the people as possible. And in doing so, create more awareness, and more people will seek for these services, including early diagnosis and screening. And also that goes to do with training of health workers or health providers in cancer screening that we have embarked on, and we hope that with these efforts we will improve the coverage of cancer screening services in the country. Thank you.
Thank you. Okay, Honorable Nyambose.
Thank you, Chair. Mine is on page 3. To increase percentage of pregnant women attending the antenatal care in the first trimester to 33%. This target was met at 33.4%, and particularly I will refer, Chair, the PS and the team to my constituency. In my constituency, there is a tradition that if you miss attending to antenatal, they are charged some money, or to stop them from avoiding antenatal and giving birth from homes. And this, they have met this requirement. They always attend. But when you visit all the health centers in my constituency, you find, other than the expectant mothers, you find those who accompany them to see them during that period, sometimes more than the number of the expectant mothers, and they stay there for sometimes more than a month or two. Now, the question that has always been coming to me is, why is it that way in the rural areas than what I see in the urbanized centers? And if these mothers are able to attend the trimester, which is 3 months period, and they adhere to those requirements, why is it that there is no accuracy to determine which period one would give birth, so that we reduce the support, those who support them during that period, because they end up contracting diseases even themselves because of the environment that are in these areas. So if we are meeting these targets, why do we still have this situation in those areas, and what should we do? What recommendation would be the team making, especially for us from rural constituencies? Thank you.
Thank you. Honorable Kafaya.
Honorable Chair, thank you so much. I have two questions for the PS. First, I would like to find out what tool you used to assess performance of the implementation of the 8th National Development Plan in 2022, given that there is no implementation schedule accompanying the plan. That's the question number 1. Then question number 2 relates to cancer. I must say I'm very happy to hear that you plan on increasing cancer screening. My question is, at the Cancer Diseases Hospital, the 2 brachytherapy units worked below 50% in the year under review. That was the case for the Cobalt 60 units, the 2 units which are there. It was also the case for the linear accelerator. In many cases, those units were broken down. With this planned increase in cancer screening, you may arrive at a situation where you have more cancer patients who may require radiotherapy. Now, given the condition of your radiotherapy units at Cancer Diseases Hospital, how do you hope to manage the increased caseload that is going to arise from your increased cancer screening? I know that in the period under review, chemotherapy should have been a serious problem as well, because chemotherapeutic reagents should have been affected the same way all other drugs were affected. I think it's common knowledge that drugs have been a problem in 2022 in our country. So those are my two questions, Honorable Chair. Thank you so much.
Thank you. Now, PS, you can respond to those and then we'll close.
Thank you, Honorable Chairperson. On tools used to assess implementation, I'll ask the Director M&D to chip in. Why overstaying if the mothers are attending all the 3 trimesters? Do you want to comment? Yeah.
Yeah. Thank you, Pierre. Thank you, Chair. We did use the preliminary framework that we started developing with guidance from Ministry of Finance earlier on, but the templates kept on changing. Hence, some of the shifts that we may have even encountered in terms of the numbers. So Ministry of Finance guided. So I think the time we were making the submission, what is now in circulation as the draft was the framework that was used. But we are aware that the final one is yet to be released and approved. I submit.
Chair and honorable members of the committee, on the issue of antenatal attendance in the first trimester, I think what we're trying to address on this indicator is to allow our pregnant women to come to the health facility as early as possible. In the past, we only measured how quickly this woman came. It didn't matter what time they came during their pregnancy. But with new research, it has shown that the earlier the woman books for antenatal and starts receiving interventions, like we have mentioned in that indicator, deworming, anemia, testing for syphilis, HIV testing early, and giving them ITNs, if they are done in the first part of their pregnancy, that's the first trimester, then the outcomes of the pregnancy are better. But what we have seen is that most of our women, in fact, the greatest myth we have in the community is that most women are told that we should not talk about our pregnancy before it shows. And so they don't come during their first trimester, because during their first trimester, the pregnancy is not showing. So this is the reason that we are seeing a very low performance on this indicator. They don't come, and we're trying to improve on our health education so that they can come in time to receive the interventions that have been provided. This is an ongoing activity, and I think it will take a while before we get there. We need everybody, all concerted efforts from different players and stakeholders to help us get our women to come early. Now, when they do start coming for antenatal, it helps us identify risks in their pregnancy, and if at such a time of their visit we find that there is a risk to that pregnancy, rather than have the woman go back home and increase the chances of not having her not have her baby, or even probably herself dying because of this pregnancy, we ask them to come to the hospital and stay near to a healthcare provider. The reason it's like that in the rural area is because the clinic is probably too far away, and so they can't come and go when we need them. And so we create what we call waiting homes, and we ask them to stay there. But the nature of our culture is such that you cannot leave such a woman alone with people that are perceived to be maybe strangers, like the health workers. In the urban areas, it happens as well. The women are kept in the ward, sometimes for long periods of time. But because of the way urban areas are, the family will probably be coming and going to visit rather than stay there for that period of time. So I think it's just a matter of educating our communities. When a woman has been brought nearer to the health center, maybe the trust should be in the healthcare service, because they'll look after this woman until it's time to deliver. We don't want her to go back home and risk losing her or the unborn baby because they went back and were not taken care of. Thank you, Chair.
Thank you.
Honorable Chairperson, there was a question on that we are increasing awareness on the uptake of cancer screening services. Yes, again, knowledge is power. It is important that our people know their status, and we encourage screening for early detection of these cancers. As you know that when they are detected early, they are easier to manage. Honorable Chairperson and Honorable Committee members would like to report that there is, the Ministry is currently working on a program to ensure that the equipment at the Cancer Disease Hospital, the obsolete equipment, which unfortunately for some time now has not been given adequate maintenance attention. We are working on the program now that equipment is obsolete and has outlived its usefulness. We've embarked on a program to decommission that equipment, the Linux, the Cobalt 60 and so on, and other cancer treatment machines, to ensure that we decommission those machines, and after decommissioning them, we revisit the infrastructure and ensure that we re-equip the Cancer Disease Hospital as soon as possible. We are aware of the urgency on this matter, and hence the response that we have put in place in terms of securing equipment through various models, through a public-private partnership model of decommissioning because of the radioactivity nature of materials being used, to ensure that the equipment is safely decommissioned and the structures are refurbished and ready to receive new equipment that will support management of cancer patients in the country. But in addition to that, we have already started the Greenfield project in Ndola, which is timed for 12 months, after which a fully fledged and fully equipped hospital will be handed over to the government, to operate. And we are not stopping there in terms of decentralizing the service. We hope not far from now we'll be announcing a similar cancer treatment center in Livingstone. And we'll continue to do this case to the need for ensuring that we bring cancer management services as close to the people as possible, for this is our vision in all parts of the country. So we are resolved, Honorable Chair, to ensure that even as we increase the demand on one hand, on the other side we are providing adequate facilities, medical facilities for managing these cancers. I submit. Thank you.
Thank you. And that process of just decommissioning and assessing the equipment and also putting in place the new structures to accommodate the earmarked new equipment, how long will that take?
We are trying to work roughly under a period of all things being equal, under a task committee constituted by the Cabinet of Permanent Secretaries and Ministers. We hope all things being equal, this whole process should be complete in less than 12 months. I submit.
Thank you. Okay, honorable members, this is where we end. Okay. Okay, there's another one thing. Honorable members, this is now past 13 hours and we should be preparing. Yeah, Honorable Kafwe, you can if I have a question for you, Honorable Dr. Kalila, which I should have asked them. I know you answered it. Honorable Kafwe, you can. Thank you. Thank you, honorable members. PS and your team, we want to thank you most sincerely for coming. You have been in these premises now for more than 2 hours. We appreciate. In terms of the provisions of the immunity, also ND in terms of cut-off, and we can only wish you the best for the rest of this day. Thank you very much for coming once again.
Thank you, Honorable Chairperson, and thank you, committee members.
Thank you.
Thank you.
This June, the stars of Zambezi Magic are perfectly aligned. It's a gamble for stardom on the all-new 10 Tamanga Street. Bold steps push Zuba to a league above all. Lindiwe plays puppet master as her devious plan unfolds. With the hope of reconciliation, Shimumbi returns to Ranamumbi. Witness Uncle Imbani's hustle and bustle for the upper life. And get up close and personal with our favorite